So we are going to the muscles of the arm. You know the arm is between the shoulder joint and the elbow joint. And the arm has two compartments of muscles, the anterior compartment and the posterior compartment. The anterior compartment has 3 muscles, whereas the posterior compartment has 2 muscles. So the muscles of the anterior compartment, from superficial to deep, we are going to begin with the biceps brachii. And this muscle, biceps brachii, it's known as biceps because it has two bellies. There is what we call the long head, and then what we call the short head. The long head originates from the supraglenoid tubercle of the scapula, and the short head originates from the coracoid process. And this muscle will insert, its bellies will unite, and the tendon is going to insert onto the radial tuberosity. Part of its tendon is going to become an aponeurosis, or a tough membrane, and that aponeurosis is known as the bicipital aponeurosis, and it will insert deep into skin. So part of its tendon inserts in the radial tuberosity, and part of its tendon inserts deep within the subcutaneous tissue of skin, and it is known as a bicipital aponeurosis. So this is the muscle known as biceps, and it is going to participate in the flexion of the elbow joint as a principal action, but there are other actions. And it is supplied by the musculocutaneous nerve, as indicated in the table there, with roots C5 and C6. So it is a flexor of the forearm at the elbow joint, but also has an action of supination, and that is biceps brachii. Long head, short head, it supinates and flexes the elbow joint, supplied by the musculocutaneous nerve, a branch of the lateral cord of the brachial plexus, and with roots C5 and C6. Deep to the biceps brachii, we have that muscle known as brachialis, also supplied by the musculocutaneous nerve. So this muscle brachialis originates from the lower half of the shaft of the humerus and inserts in the coronoid process of the ulna. It flexes the elbow joint, and it is supplied by the musculocutaneous nerve. The third muscle is the coracobrachialis, originating from the coracoid process and inserting in the medial aspect of the midshaft of the humerus. That is known as coracobrachialis. It participates in the flexion of the shoulder joint, or you can say flexion at the shoulder joint, and also adduction at the same joint. Adduction and flexion of the shoulder joint, coracobrachialis, also supplied by the musculocutaneous nerve. So all muscles of the anterior compartment of the arm, namely biceps brachii, brachialis, and coracobrachialis, are supplied by the musculocutaneous nerve. We have talked about their origins and insertions. On top of them is biceps brachii. The other ones are hidden below. The posterior compartment of the arm has 2 muscles. One of them is known as triceps brachii because it has 3 bellies: the long head, the medial head, and the lateral head. The long head, the medial head, and the lateral head. That is triceps brachii. And when we look at it, this is the long head. The long head originates from the infraglenoid tubercle of the scapula. Then the lateral head originates from the superior aspect of the shaft of the humerus above the radial groove. This is the radial nerve passing through the radial groove. So you can see the origin of the lateral head is above the radial groove on the posterior surface of the shaft of the humerus. And the medial head is below the radial groove, also on the posterior aspect of the shaft of the humerus. So this is the long head, origin infraglenoid tubercle of the scapula. Medial head, posterior surface of the shaft of the humerus, inferior to the radial groove. Lateral head, posterior surface of the shaft of the humerus, superior to the radial groove. These bellies of the triceps muscle come together and they form a common tendon which inserts in the olecranon process of the ulna. And this muscle is supplied by the radial nerve, and it is the chief extensor of the elbow joint, that is triceps brachii. The other muscle is known as the anconeus. The other muscle is known as the anconeus. Anconeus originates from the lateral epicondyle and it fans out in a triangular format and inserts on the posterior surface of the ulna on the olecranon process. So it is posterior to the elbow joint, originating from the medial epicondyle and inserting in the olecranon process of the ulna posteriorly. And it assists the triceps brachii in the extension of the elbow joint, and it is also supplied by the radial nerve. So the muscles of the posterior compartment of the arm will have the triceps brachii and then the muscle known as the anconeus. Cubital fossa. Let's look at the region known as the cubital fossa. The cubital fossa, the other name is known as the elbow pit. It is a triangular depression on the anterior aspect of the elbow joint. So that triangular depression on the anterior aspect of the elbow joint is known as the cubital fossa. So this is what I mean. This is known as the cubital fossa, this triangular depression, and it is used for a number of clinical procedures. The cubital fossa contains nerves and blood vessels, but the danger is that those nerves and blood vessels are only covered by skin and superficial fascia. So, on a positive note, those blood vessels can be accessed easily for clinical procedures, but on a negative note, because they are only covered by skin and superficial fascia, they can easily be injured. The cubital fossa has a medial border. This is a lateral border. It has a lateral border. It has a medial border, and it has a superior border. The borders are very important. It has a lateral border, a medial border, and a superior border. And the medial border, you can see, this is the medial border. It is made up of this muscle known as Pronator teres. It is a muscle of the anterior compartment of the forearm. So the medial border is made up of this muscle known as Pronator teres. But I want you to pay attention to this. This Pronator teres has a medial boundary and a lateral boundary. It has a medial boundary and a lateral boundary. So when we say that the Pronator teres forms the medial border, but specifically its lateral boundary is the one which forms the medial border of the cubital fossa. The lateral border is formed by this muscle known as brachioradialis. Brachioradialis also has a lateral border or lateral boundary and medial boundary. Lateral boundary and medial boundary. So when we say that the lateral border of the cubital fossa is formed by this muscle known as brachioradialis, we are referring to the medial boundary. So it is the medial boundary of the brachioradialis which forms the lateral border of the cubital fossa. The superior border is formed by an imaginary line between the medial epicondyle and lateral epicondyle. An imaginary line, meaning that it does not exist, you imagine it, between the medial epicondyle and lateral epicondyle. So these are the borders of the cubital fossa. This cubital fossa has a floor. The cubital fossa has a floor. The floor of the cubital fossa is made up of the brachialis muscle and the supinator muscle. We have talked about the muscle known as brachialis. It's a muscle of the arm, anterior compartment. So it comes and enters the cubital fossa and forms the floor. So the floor of the cubital fossa is formed by brachialis muscle and supinator muscle, on which the contents lie. So that is the superior border, medial border, lateral border, and the floor is formed by the brachialis muscle and supinator muscle. What do we find on the inside of the cubital fossa? What are the contents of the cubital fossa? The contents of the cubital fossa are named in order. So these are the contents of the cubital fossa. You have the median nerve. From medial to lateral, you have the median nerve. Then you have the brachial artery and its branches. The brachial artery and its branches. Then you have the tendon of biceps brachii as it is going to start on the radiotuberosity, and then you have the radial nerve. So from medial to lateral, you have the median nerve, the brachial artery and its branches, the biceps tendon, and then the radial nerve. These are the contents of the cubital fossa from medial to lateral. You can also name them from lateral to medial as long as they are named in order. What covers these contents? What covers these contents? Remember when I was talking about biceps brachii, I talked about what we call the bicipital aponeurosis. Part of the biceps tendon becomes an aponeurosis and inserts into skin. So this bicipital aponeurosis, as it's going to insert into skin, covers the contents of the cubital fossa, so they are below it. So when we say the roof of the cubital fossa, the roof of the cubital fossa is the bicipital aponeurosis, superficial fascia, and the skin. So they are only covered by the bicipital aponeurosis, superficial fascia, and skin. So any penetrating injury there can easily injure these contents of the cubital fossa. The roof of the cubital fossa, I said, is the bicipital aponeurosis, the subcutaneous tissue, and the skin. Meaning that these structures pass below the roof. As you can see, this is the bicipital aponeurosis. So you can see the blood, the nerves and blood vessels. This is the radial nerve. This is you can see the tendon of biceps brachii. You can see the brachial artery and the median nerve. They are passing below the bicipital aponeurosis. So the bicipital aponeurosis, the skin and the subcutaneous fat form the roof of the cubital fossa. So what is the clinical significance of the cubital fossa? When you're measuring blood pressure, the stethoscope is placed above on the surface of the roof of the cubital fossa. When you're measuring blood pressure, the stethoscope is placed on the roof of the cubital fossa, and that stethoscope is going to listen or to enable you to listen or to auscultate the pulsations of the brachial artery. So you can palpate or auscultate. To palpate is to touch and sense. To auscultate is to put a stethoscope and listen to. So they can use it to auscultate the pulsations of the brachial artery because it is only covered by skin and fascia So you can easily auscultate or palpate the pulsations to measure the blood pressure. They can perform an action known as the action, for example, known as phlebotomy. Phlebotomy refers to puncture of blood vessels. When you look at the roof of the cubital fossa, the roof of the cubital fossa contains veins. And these are the veins which are used for that clinical procedure known as phlebotomy. Phlebotomy is to puncture a blood vessel. For example, they puncture these blood vessels to draw blood for laboratory investigations. They can puncture these blood vessels to insert small tubes known as catheters. So these veins are within the roof. They are not contents. These veins are within the roof of the cubital fossa, and they are used for clinical procedures because they are just below skin, so they are easily accessible. When they are carrying out those clinical procedures like phlebotomy, they do not go to the contents of the cubital fossa. So when someone is handling a cubital fossa and they are trying to insert the needle in a vertical orientation, they are going to go and injure the nerves and blood vessels. They only go below skin, percutaneous, to access the veins of the roof. Those are the veins which you must access when you are doing phlebotomy. But when you go deep, you're going to injure the radial nerve, you're going to injure the medial nerve, you're going to injure the brachial artery. So there should not be anyone to tamper with the contents of the cubital fossa, with the exception of a few procedures. The veins which are used are the veins within the roof. The veins within the roof are the ones which are used. So when we look at that clinical procedure known as phlebotomy, that is the puncture of blood vessels. Puncture of blood vessels. For example, they can insert what we call a central catheter and navigate it up through this vein. This vein is known as a basilic vein. It is in the roof of the cubital fossa. So they insert a central catheter within the basilic vein, and then they navigate up until the catheter reaches the axillary vein, and then they take it to the brachiocephalic vein, superior vena cava, until it reaches the right atrium of the heart, and they can inject a contrast medium there to outline maybe the chambers or blood vessels of the heart. This is one of the procedures which is used when they are accessing the veins of the roof of the cubital fossa. Those veins can also be used to draw blood samples. For example, you have this vein which is in the roof of the cubital fossa known as the cephalic vein, and the medial vein is known as the basilic vein, and they are joined together by what you call the median cubital vein. These are the veins within the roof of the cubital fossa: the cephalic vein, the basilic vein, and the median cubital vein. These are the veins that they use to draw blood samples for laboratory investigations. They can also insert their IV lines. For example, if they are going to administer normal saline, like drips, they insert those needles inside these veins. Because they are easily accessible, they are in the roof, and there is no danger of injuring the contents of the cubital fossa. The arrangement of these veins within the roof of the cubital fossa varies amongst individuals. Some individuals have a cephalic vein on the lateral aspect and a basilic vein on the lateral aspect as usual, and they are joined by one oblique median cubital vein. Whereas other individuals have a cephalic vein on the lateral side and the basilic vein on the medial side as usual, but they have a different format of the median cubital vein. There is a tributary which is draining into the cephalic vein known as the median cephalic vein, and another one known as the median basilic vein. So this is the format in some individuals, whereas the other individuals, this is the other format. However, what matters is that these veins are within the roof of the cubital fossa and they can easily be accessed for laboratory investigations. So that is what I can say when it comes to the muscles of the arm. The anterior compartment muscles, we have looked at them, and the posterior compartment muscles, we have looked at them. We have also looked at the cubital fossa, its boundaries, its flow, its roof, its contents, and its clinical significance. We proceed to the muscles of the forearm. As you know, the forearm is between the elbow joint and the wrist joint. The forearm is also having two compartments. The forearm has an anterior compartment and a posterior compartment. I repeat, the forearm has an anterior compartment of muscles and a posterior compartment of muscles. The muscles of the anterior compartment have action of flexion and pronation. The muscles of the anterior compartment of the forearm have actions of flexion and pronation. They perform flexion at the wrist joint, at the carpal, metacarpal joints, at the metacarpal phalangeal joints, and at the interphalangeal joints, as we shall see. And they also perform pronation of the forearm. Those are the muscles of the anterior compartment. The muscles of the posterior compartment perform two actions: supination and extension. It means that the actions of the muscles of the posterior compartment are antagonistic to the actions of the muscles of the anterior compartment. So the muscles of the posterior compartment extend at the wrist joint, at the carpal, metacarpal joints, at the metacarpal phalangeal joints, and at the interphalangeal joints, and they also supinate. So we are going to begin by looking at the muscles of the anterior compartment of the forearm. We are going to begin by looking at the muscles of the anterior compartment of the forearm. All these muscles, you must know them without leaving out any. The anterior compartment of the forearm has muscles, and those muscles are divided into three layers. The superficial layer on top, below it you have the intermediate layer, and then deepest you have the deep layer. So the muscles of the anterior compartment of the forearm are separated into three layers: the superficial layer, the intermediate layer, and the deep layer. So we are going to begin with the muscles of the superficial layer. We are going to begin with the muscles of the superficial layer. The muscles of the superficial layer are pronator, teres. Pronator, teres, originating from the medial epicondyle and part of it from the ulna. And then it is going to go and insert in the mid shaft of the radius. This muscle is known as the pronator teres. And as the name suggests, it pronates the forearm at the elbow joint. And it is supplied by the median nerve. And that is the muscle that we looked at there, pronator teres. So this is the muscle, pronator teres, from the medial epicondyle to the mid shaft of the radius. Medial epicondyle and some fibers from the ulna. We are looking at the muscles of the superficial layer of the anterior compartment of the forearm. Next to it is this muscle known as the flexor because it flexes, carpi because it attaches on the metacarpals, radialis because it is more lateral. So this muscle flexor carpi radialis originates from the medial epicondyle. It goes and inserts on metacarpal 2 and metacarpal 3. It goes and inserts on metacarpal 2 and metacarpal 3. This is the flexor carpi radialis, also supplied by the median nerve and it flexes the wrist joint. It flexes the wrist joint and the carpal, metacarpal joints. It is also supplied by the median nerve. Next to it is this muscle known as Palmaris longus. Palmaris longus, also originating from the medial epicondyle, and it inserts in this aponeurosis of the palm known as the Palmar aponeurosis. It is the tough membranous tissue below the skin of the palm. So this muscle is known as the Palmaris longus. From the medial epicondyle, it inserts in the Palmar aponeurosis, and it is the flexor of the wrist joint, also supplied by the median nerve. Then the most medial muscle is known as the flexor carpi ulnaris from the medial epicondyle, and it goes and inserts in the pisiform bone. Flexor carpi ulnaris from the medial epicondyle and inserts in the pisiform bone. And I've talked about it here, that muscle, flexor carpi ulnaris. Now, flexor carpi ulnaris is supplied by the ulnar nerve, whereas the Pronator teres, flexor carpi radialis, Palmaris longus, these muscles are supplied by the median nerve. The flexor carpi ulnaris is supplied by the ulnar nerve, and it is a flexor of the wrist joint and also adducts at the wrist joint. These are the muscles of the superficial layer of the anterior compartment of the forearm, and they have a common origin, which is the medial epicondyle. All of them are supplied by the median nerve, except the flexor carpi ulnaris, which is supplied by the ulnar nerve. Deep to these muscles of the superficial layer, we have a muscle of the intermediate layer. This muscle of the intermediate layer lies deep to the muscles of the superficial layer. And this muscle is known as the flexor because it flexes, digitorum, it flexes the digits superficialis because it is on top of another muscle which also is similar to it. So the muscle known as flexor digitorum superficialis is the muscle of the intermediate layer of the forearm. Origin, medial epicondyle and the radius. It has an attachment from the on the medial epicondyle and the radius. When it reaches the wrist joint, it splits into 4 tendons, and it sends a tendon to the small finger, the ring finger, the middle finger, and the index finger. It does not send a tendon to the thumb. So it splits into 4 tendons at the wrist, and it goes and its tendons divide into 2 slips, as you can see. Its tendons divide into 2 slips, as you can see, and those slips attach at the base of the middle phalanx. The slips attach at the base of the middle phalanx. So this muscle, because the slips attach at the base of the middle phalanx, it participates in the flexion of this joint. And this joint is the proximal interphalangeal joint. It also participates in the flexion of the carpal, metacarpal joint, and also it participates in the flexion of the proximal interphalangeal joint, the metacarpal phalangeal joints, and the carpal metacarpal joints. This is known as the flexor digitorum superficialis. It is supplied by the median nerve, and it is the muscle of the intermediate layer of the anterior compartment of the forearm. Deep to this muscle are the muscles of the deep layer. They are the muscles of the deep layer. This is the muscle we have been talking about, flexor digitorum superficialis. Now, deep to the flexor digitorum superficialis, we have muscles of the deep layer. These muscles are deep to this. So the muscles of the deep layer are flexor digitorum profundus, flexor pollicis longus, and then we have another muscle known as the Pronator quadratus, as we shall see. So the muscles of the deep layer are the flexor digitorum profundus, this muscle, flexor digitorum profundus, originating from the coronoid process of the ulna and the interosseous membrane. These two bones, the radius and the ulna, in between them there is a membrane known as the interosseous membrane. Inter means between, osseous, bone. So this muscle from the ulna and interosseous membrane, that's its origin, it comes and does the same thing that flexor digitorum superficialis does. It splits into 4 tendons, to this lateral, to this medial, 4 digits. But the tendons, I want you to observe this carefully. These are the tendons of the flexor digitorum superficialis, and I told you that they divide into 2 slips and they insert at the base of the middle phalanx. However, the tendons of flexor digitorum profundus are going to go and pass in between the slips of the tendons of flexor digitorum superficialis, and they will go and insert at the base of the distal phalanx. That is why the muscle of flexor digitorum profundus flexes the distal interphalangeal joint, the metacarpal phalangeal joints, and the carpal metacarpal joints. That is one of the muscles of the, deep layer of the anterior compartment of the forearm. The other muscle of the deep layer is flexor pollicis. The word pollicis means thumb, longus. Longus because it inserts on the distal, its tendon inserts on the distal phalanx and participates in the flexion of this interphalangeal joint. So this muscle originates from the interosseous membrane and the distal shaft of the radius, and its tendon is going to come and it's going to insert at the base of the distal phalanx. It participates in the flexion of the interphalangeal joint of the thumb, the metacarpal phalangeal joint, and the carpal metacarpal joints. This muscle flexor pollicis longus. The flexor digitorum profundus, and I want you to listen to this. The flexor digitorum profundus, the medial part is supplied by the ulnar nerve, the lateral part is supplied by the median nerve. The medial half is supplied by the ulnar nerve, the lateral half is supplied by the median nerve. The flexor pollicis longus is supplied by the median nerve, and we shall make a conclusion of that. The other muscle of the deep layer is the Pronator quadratus. It pronates. Remember, we had a pronator in the superficial layer known as the Pronator teres. So it has a counterpart in the deep layer known as the Pronator quadratus. That is because it pronates and it is roughly 4-sided. So this Pronator quadratus originates from the anterior surface of the distal shaft of the ulna and inserts on the anterior surface of the distal shaft of the radius. It is supplied by the median nerve, and its action is the pronation of the forearm. So it works hand in hand with the Pronator teres. This Pronator teres is in the superficial layer, Pronator quadratus in the deep layer. Both of them pronate the forearm. Remember, I said that the muscles of the anterior compartment of the forearm extend and flex, not extend, flex and pronate. So these are some of the images showing you the muscles, and we say the superficial layer is made up of the Pronator teres, Flexor carpi radialis, Palmaris longus, and the Flexor carpi ulnaris. The intermediate layer is made up of the Flexor digitorum superficialis, and the deep layer is made up of the flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. All the muscles of the anterior compartment of the forearm, I repeat, all the muscles of the anterior compartment of the forearm are supplied by the median nerve, except flexor carpi ulnaris, which we saw in the superficial layer, and the medial half of the flexor digitorum profundus, which we saw in the deep layer. So that is a summary of the muscles of the anterior compartment of the forearm. Now let us go to the posterior compartment of the forearm. Let us go to the posterior compartment of the forearm. And the muscles of the posterior compartment of the forearm extend and supinate, which actions are antagonistic to the muscles of the anterior compartment of the forearm. And we should also know that all muscles of the posterior compartment of the forearm are supplied by the radial nerve. All muscles of the posterior compartment of the forearm are supplied by the radial nerve, which is the terminal branch of the posterior cord of the brachial plexus. Remember, even if you make a cross section through the forearm, the anterior compartment is going to show you the muscles of the superficial layer on top, muscles of the intermediate layer in between, and muscles of the deep layer deep. And when you look at the muscles of the posterior compartment of the forearm, for them they are divided into two layers. The one for the anterior compartment has 3 layers, but the ones for the posterior compartment have two layers. The superficial layer and the deep layer. The superficial layer and the deep layer. And these layers are separated by a layer of connective tissue. A layer of connective tissue dividing the muscles of the superficial and the deep. So we are going to begin with this muscle known as brachioradialis. Now, brachioradialis has some characteristics of the muscles of the anterior compartment of the forearm, but it also has characteristics of muscles of the posterior compartment of the forearm. How? It is a flexor of the elbow, which is a characteristic of muscles of the anterior compartment of the arm. And on the other hand, it is supplied by the radial nerve, which is a characteristic of muscles of the posterior compartment of the forearm. So some literature places it under the muscles of the anterior compartment, others place it under the muscles of the posterior compartment. However, that does not matter. What matters is that you know its anatomy and action. So this muscle originates from the supracondyle ridge of the humerus and inserts in the styloid process of the radius. So it is originating from the supracondyle ridge of the humerus and inserting in the styloid process of the radius. It's supplied by the radial nerve and it's a flexor of the elbow. It is one of the muscles of the superficial layer of the posterior compartment of the forearm. Now we have these two muscles, extensor carpi radialis longus and extensor carpi radialis brevis. These are two muscles, extensor carpi radialis longus and extensor carpi radialis brevis. We are on the muscles of the superficial layer of the posterior compartments of the forearm. So the longus, because it is longer than the brevis, that is why the longus originates from the supracondyle ridge, lateral supracondylar ridge, and the brevis means shorter, originating from the lateral epicondyle. And they insert in metacarpals 2 and 3. So extensor carpi radialis longus, extensor carpi radialis brevis. I don't know whether I have other illustrations which are better than that one, but if I do not have, we shall look at them later. Extensor carpi radialis longus and extensor carpi radialis brevis. This one originates from the lateral supracondylar ridge. This one originates from the lateral epicondyle, and they insert in metacarpal 2 and 3. Those are the other muscles of the superficial layer of the posterior compartment of the forearm. We looked at the brachioradialis, now we're looking at these two. And these two are extensors at the wrist, extensors and abductors at the wrist joint. So far we have looked at 3 muscles: brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis. Now, this muscle is known as extensor digitorum. It is an antagonist of the other 2 muscles we saw. Extensor digitorum is an antagonist of the other 2 muscles, flexor digitorum superficialis and flexor digitorum profundus. So we do not have a superficialis and a profundus for the extensors, only have extensor digitorum. And it originates from the lateral epicondyle. And inserts, it also divides into 4 tendons and inserts in the extensor hood. Let's go and look at what the extensor hood is. These are the tendons of the extensor digitorum. Let's continue. This muscle is extensor digitorum. The wrist is also divided into 4 tendons, which are going to insert in the lateral 4 digits. But these 4 tendons, as you see them, they are going to insert in what we call the extensor hood. When you look at the extensor hood, this is on the posterior aspect of the metacarpal phalangeal joints, where many tendons meet and they fuse. Tendons meet at this point and they fuse. This is what we call the extensor hood. So the 4 tendons go and insert in the extensor hood. That is the extensor digitorum. Now I want you to see, when the extensor digitorum tendons reach the extensor hood, they split into 3 splits. They split, forming 3 slips. And I want you to observe, 2 slips move laterally and 1 slip moves in the middle. The middle slip of the tendon of the extensor digitorum is going to go and insert at the base of the middle phalanx, and therefore it participates in the flexion of the extension, not flexion. The middle slip goes and inserts at the base of the middle phalanx and participates in the flexion of the proximal interphalangeal joint. Then these 2 lateral slips will move laterally and fuse, and then they will insert at the base of the distal phalanx and therefore participate in the extension of the distal interphalangeal joint. Remember, these 2 joints are flexed by flexors, flexor digitorum superficialis and flexor digitorum profundus. So this muscle, extensor digitorum, is antagonizing those 2 muscles by extending these 2 joints. Extensor digitorum. Then we have what we call extensor digiti minimi. Whenever you see the word digiti minimi, it means small digit or small finger. And extensor digiti minimi also participates in the extension of the small finger, originating from the lateral epicondyle and also inserting in the extensor hood. For example, this muscle, the extensor digiti minimi, can be demonstrated here. This one, colored green, extensor digiti minimi, it comes and joins the tendon of extensor digitorum, which comes with the small finger, and they insert in the extensor hood and participates in the extension of the small finger. And then we have extensor carpi ulnaris. This is an antagonist of flexor carpi ulnaris. So it also originates from the lateral epicondyle, and then it will insert in the metacarpal number 4. Metacarpal number 4, it extends the wrist. That is the extensor carpi ulnaris. It comes and inserts at metacarpal. This metacarpal is number 4, around there between number 4 and number 5, and participates in the extension of the wrist. So brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris. These are the muscles of the superficial layer of the posterior compartment of the forearm, and all of them are supplied by the radial nerve. The deep muscles, the muscles of the deep layer of the posterior compartment of the forearm. The word pollicis means thumb. The word pollicis means thumb. So 3 of these muscles of the deep layer, abductor pollicis longus, which abducts the thumb, extensor pollicis brevis, which extends the thumb, extensor pollicis longus, which also participates in the extension of the thumb. These 3 muscles of the deep layer act on the thumb, whereas the supinator and the extensor indicis, the supinator supinates, and this muscle is the one which antagonizes the pronators of the anterior compartment. Extensor indicis, it extends the index finger. So, with the exception of supinator and extensor indicis, the other muscles of the deep layer act on the thumb. So the supinator, as the name suggests, supinates the forearm and supplied by the radial nerve. It originates from the lateral epicondyle of the humerus and inserts on the posterior surface of the ulna. So the supinator muscle, we can see it here. Originating from the lateral epicondyle, it comes and inserts on the posterior surface. It has a wider insertion, posterior surface of the ulna. So that is what we mean by its insertion, posterior surface of the ulna. Origin, it originates from the lateral epicondyle, inserts at the posterior surface of the ulna, and when it contracts, it opposes the pronator teres and the pronator quadratus by supinating the forearm. This muscle, as the name suggests, abducts the thumb. Abducts the thumb. Abductor pollicis longus. It abducts the thumb. And have it this muscle. It's known as abductor pollicis longus, one of the muscles of the deep layer which participate in the action of the thumb, the abductor pollicis longus. Origin interosseous membrane. Insertion metacarpal 1. The metacarpal 1 is the metacarpal of the thumb. So you see that it is this muscle from the interosseous membrane and inserts at the base of the metacarpal number 1, and it abducts the thumb. Then we have the extensor pollicis brevis, and there is also what we call the extensor pollicis longus. They extend the thumb. Extensor pollicis brevis extends the metacarpal phalangeal joint and the carpal metacarpal joint of the thumb. Extensor pollicis. Whereas that's extensor pollicis longus, brevis. Extensor pollicis brevis extends the metacarpal phalangeal joint and the carpal metacarpal joint of the thumb. Whereas the extensor pollicis longus extends all joints of the thumb because it's long. The carpal metacarpal, the metacarpal phalangeal, and the interphalangeal joints. Both of them are supplied by the radial nerve. The brevis from the posterior surface of the radius and inserts at the base of the proximal phalanx. And the longus from the posterior surface of the ulna and inserts at the base of the distal phalanx. So this is the brevis. This is the longus. The longus, you can see it's going to insert at the base of the distal phalanx. The brevis is going to insert at the base of the proximal phalanx. Brevis originating from the interosseous membrane, longus originating from the posterior surface of the ulna. Extensor, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and then the supinator. Then the last muscle is the extensor indicis. As the name suggests, it extends the index finger. It is originating from the ulna and the interosseous membrane and inserts in the extensor hood. This is the extensor indicis from the ulna and interosseous membrane and goes and inserts in the extensor hood, as you can see there. So those are the muscles of the deep layer of the posterior compartment of the forearm. All of them are supplied by the radial nerve. And the muscles of the superficial layer participate in the extension of the wrist joint. The muscles of the superficial layer participate in the extension of the wrist joint, meaning that if the radial nerve is injured, you will not be able to extend the wrist joint, and you're going to have a condition known as wrist drop. Wrist drop means that you cannot extend the wrist joint because of injury to the radial nerve, which supplies the muscles of the superficial layer of the posterior compartment of the forearm, which take action of extending the wrist joint. So the muscles of the anterior compartment of the forearm superficial layer are going to be unopposed and they are going to flex. So that is what they mean by wrist joint. You can make a cross section through the muscles of the forearm. You go and look for that image, which shows you the cross section of the muscles of the forearm, and you see those layers, how they are arranged one on top of the other. Some of the related fractures, and these fractures are on the distal aspect of the forearm. There's a fracture known as Cole's fracture. There is a fracture known as Cole's fracture. Cole's fracture occurs at the distal end of the radius. When a bone fractures, it will have what we call a proximal fragment and a distal fragment. A proximal fragment and a distal fragment. So when you look at this word, Cole's fracture, and we talked about the fragments, the proximal fragments and distal fragments, that is what we mean. So in Cole's fracture, it's a fracture of the distal radius, where the distal fragment is tilted posteriorly. So you fall on an outstretched arm. And the force which is transmitted through the radius fractures the distal radius. The proximal fragment displaces posteriorly, and then the distal fragment displaces anteriorly. And that is what we call the Cole's fracture. And then it is what forms what we call the dinner fork deformity. Okay? It forms what you call the dinner fork deformity. So you can see the proximal fragment displacing posteriorly, and the proximal fragment displacing posteriorly, and the distal fragment displacing anteriorly. Smith's fracture is the opposite of Cole's fracture, whereby you fall on the dorsum of the hand, and this causes the proximal fragment to displace anteriorly and the distal fragment to displace posteriorly. These two fractures are very common in the distal aspect of the forearm. So here we are seeing the proximal fragment displacing anteriorly. This is Smith's fracture, and the distal displacing posteriorly. These are very, very important characteristics for you to appreciate. Smith's fracture and Cole's fracture. There is a couple bone known as the scaphoid. There is a couple bone known as the scaphoid. This scaphoid is known as scaphoid because it looks like a bone, a boat. This couple bone is known as the scaphoid because it looks like a boat. Now, these clinical coordinates are very, very important. I'm not just passing through them for the sake of passing through them. So this couple bone is known as the scaphoid. It is lateral. It looks like a boat. So when you fall on an outstretched arm, like in cases of the Cole's fracture, when you fall on an outstretched arm, the force transmitted through the radius can also crush it and fracture it. So you can see a fracture of the scaphoid obtained when you fall on an outstretched arm. And what is the danger of that? The scaphoid receives its blood supply from the radial artery. So the radial artery gives its supply on the anterior aspect through this Palmar branch of the radial artery, and on the posterior aspect through this dorsal carpal branch of the radial artery. So the fractures of this bone are going to injure this artery and therefore cut off of blood supply to the scaphoid bone. So when the scaphoid bone is fractured, its blood supply is interfered with and is cut off from this bone. So this bone is going to die off because of lack of blood supply, a condition we call avascular necrosis. Avascular necrosis of the scaphoid bone, which is going to make the wrist joint unstable because of fractures of the scaphoid bone. You go and look into this in detail. On the medial aspect, we have another bone known as the hamate. On the medial aspect, we have another bone known as the hamate. And that is the carpal bone which is hooked. I don't know whether you looked at the hamate bone when you were looking at your osteology. So this bone on the medial aspect, the scaphoid is lateral, the hamate is medial. It is known as the hamate bone. It has a hook, it is hooked. So when the fractures of the hamate bone might injure the ulnar nerve, because the ulnar nerve passes just on its anterior surface. When you look at this hamate bone, it is bridged by a ligament between the hamate bone and the pisiform bone, known as the pisihamate ligament. So this ligament is above the hamate bone, and it's between the hook of the hamate and then the pisiform bone. Deep to this ligament, the ulnar nerve passes. You see, this is the pisihamate ligament. And the ulnar nerve passes just below it. And this canal through which the ulnar nerve passes below the pisihamate ligament is known as the Guyon's canal. As I've indicated for you here, Guyon's canal. Guyon's canal is below the pisihamate ligament because this is a ligament between the pisiform bone and the hamate. and below which we have the ulnar nerve passing. So when you have the fractures of the hook of the armet, those fractures can lead to the compression of the ulnar nerve, and you're going to lose sensations on the medial third of your hand, because this ulnar nerve supplies the medial aspect or the medial third of the hand. So fractures of the armet can lead to the compression of the ulnar nerve as it passes through the Guion's canal, which is passing below the Pisiform ligament. This can lead to the compression of the ulnar nerve, leading to loss of sensations on the medial third of the hand. And that is known as the Guion's canal syndrome. You're going to have pain, numbness, tingling. Tingling is like needles are pricking you of the medial aspect of the hand, which has the ring finger and the little finger. And finally, you lose sensations, and even the muscles will become weak. The only thing they can do is to make sure that the ulnar nerve is decompressed, so that it is not being affected.